Welcome back to another episode of Quick Hits, the podcast where we explore the latest trends and innovation in healthcare technology. I'm your host, Tyler Smith, CEO of Health Data Movers. On this episode of Quick Hits, I'm joined by Nneka Sederstrom, Chief Health Equity Officer at Hennepin Healthcare. Nneka shares her journey into becoming Hennepin's first Chief Health Equity Officer, a role created in response to the powerful call for change following the death of George Floyd. She walks us through how Hennepin has taken bold steps to address racism in healthcare, including launching a year-long 36-hour anti-racism training for more than 7,000 employees. We sit down with Nneka to talk about what it takes to build a true foundation for health equity, why education and active listening are essential, and how healthcare organizations can measure progress in ways that truly matter to patients and communities. From navigating the challenges of data and identity in electronic health records to building community trust and creating a failure conference that sparks innovation, this conversation highlights what it means to lead with courage, persistence, and purpose. And for those working to advance equity in healthcare, Nneka shares why she believes everything is figure outable and how perseverance is the key to creating lasting change. Let's get into it. All right. Well, welcome back to another episode of Quick Hits. I'm your host, Tyler Smith, CEO of Health Data Movers, now a Sidious Tech company. I am going solo today, so missing my co-host, Ken Booth, but I am super thrilled to be joined by Nneka Sederstrom, the Chief Health Equity Officer at Hennepin Healthcare. Nneka, how are you doing today?
I'm doing well. How are you?
Good. So we like to get started with a little bit of background. So would love to hear kind of your journey into your role as Hennepin's first Chief Health Equity Officer.
Sure. So, like many, after George Floyd was murdered, there are many organizations that took up the call to address racism in its various forms. But Hennepin Healthcare did a little bit different, and only because we were so intimately tied to that situation. It was our EMS workers who arrived at the scene. It was our ED that pronounced him. So he died in our hands. And our county was the epicenter of the wave of change that was going across the world. The county decided to declare racism a public health crisis. And as a result of that, one of the questions they asked was, how is the healthcare system going to respond to this declaration? And the system said, well, we need to figure out a way to actually be real and honest in addressing how racism shows up in healthcare. And so they created this role, the Chief Health Equity Officer for Hennepin Healthcare System, as an attempt to try and mitigate the inequities that are in not only the county of Hennepin County, but throughout the state of Minnesota. And I am very proud and honored to serve that for the first time.
Well, congratulations on that role, and thank you for the context. Certainly a very meaningful role, especially given your location, and was not
Hmm.
aware of all the linkage to the tragic death of George Floyd. Um, as you look forward, what does a successful health equity strategy look like to you, and how do you measure progress in a way that's meaningful?
Yeah. So, first, I think you've got to establish what a strong foundation is in an organization and what does that look like. For us here and in healthcare in general, I think we are so focused on outcomes and our data being outcome driven. I mean, you hear a lot about, excellence in care and centers for excellence and all of this stuff, but it's all around outcome data. But before we get to outcome data, we got to really understand why we're even like looking for the things, trying to figure out the things, and how we're going to measure the things. So when you translate that from sort of your basic clinical practice into something a little bit more philosophical when it comes to health equity and inequities in general, you've got to really start with what is the why do we need to even pay attention to this conversation? And that begins with doing some significant education because most people don't even understand why having this conversation is necessary, especially in the healthcare space. We
Sure.
often feel like everybody has access to healthcare and everybody gets sick. So naturally, everybody gets the same thing. It's not as easily noticeable in other spaces in the world, like, education, the criminal justice system. There's real, like, stark contrasts where you can see it. But in healthcare, everybody needs a doctor, right? So
Right.
everybody should have access to it. But it makes it a little harder to explain the why. And so we have to do that, and we have to start with a very strong baseline for your hospital organization to really understand the history of racism in medicine, how medicine was established in America in general, and where we are today is a direct result of how we were in the past, right? So that education it has to be your foundation. Otherwise, you can't move towards any elements of success, whether it's strategic, whether it's innovation or anything like. You just can't do it because people will still always ask, "Why do I have to do this?" if they don't get it. So I think that once you get through that like initial hardcore education, that builds an awareness. And that awareness needs to be expanded through continuous active listening and not just listening for community and their experiences, but also believing. We tend to do a lot of like listening and then saying, well, I don't know if that's necessarily true. It is a side effect of dealing with humans and healthcare in general. We hear what patients say, and there's an automatic like, oh, you ask them how many beers do you drink in a week, and they're like four. You're like, maybe not, right? So there's this inconsistency in believing people's stories that has come across because we've had those experiences of knowing that the data that we're taking in from the people is not necessarily true. But in this space, we have to be really more attentive and active in believing in how people view what is done to them and feel as a result of what has been done to them, and then taking that as part of our success story. And then it really matters to have a lot of like really high up champions that are doing this work because the more champions you have in higher places, the better off your organization is going to be. If it's just a ground up movement, it is too hard to get actual traction and move forward trajectory. You're going to need people in high places who agree that this needs to be done. And then the strong, dedicated team of people who are willing to do the hard stuff that are on the ground level, those two match together, and then the organization can move forward. So it's more of like this 360 approach of allowing like innovation, creativity, and all this other stuff to come in, but based around the community stories, based around the education and awareness and active listening. And then when that like cacophony comes together, I think then you can get to the what are the things now that we can measure that are actually tangible.
Sure. Well, just from you talking us through all the different stakeholders and processes, it definitely seems like no light undertaking. Um,
No. It's
uh,
simple job, yes.
yeah, yeah. But I'd love to maybe if you have any examples or outcomes that you're particularly proud of, regardless of size and scale, that you've been able to get to in this role. I think it would really help our listeners understand even more of the complexity.
Yeah, sure. So, oh yeah, we have a bunch of stuff that I'm really excited about that we've done. And I'll start with the stuff that makes people actually go, "Really? Did you actually do that?" Those are always my favorite,
Yeah.
and because it feels a little bit like moving Everest. It's like you got that. How did you do that?
Right.
So one of the first things that we were able to do, in talking about like education and awareness being a strong foundation, it was an extremely difficult thing. I feel like it was probably one of the most hardest moments in my entire career, let alone this job, but my entire career was convincing my executive colleagues and our CEO that we needed to mandate a year-long 44-hour anti-racism training for everybody in the entire hospital. Just everybody, all 7,000 people. Um, if you've done any sort of mandatory trainings, there was even like a video that was made of that was made to like make fun of the fact that especially in hospitals, we absolutely hate the annual mandatory trainings. It is like
Right.
the bane of our existence. During that like 2 months to get it done, everybody's cussing it out and then being really angry. We sit down and listen to these fire safety and OSHA regulations and all these things that we're like, we don't care. We just want to get back to doing our work.
Yep.
So to have a 44-hour anything, these are like, and 45 minutes max. Like if you have a training that's longer than 3 minutes, people hate you. Now you're going into like 44 hours and it takes an entire full 365 days to do it. That
Sure.
was an impossibility. And yet we did it. I have a quote on my desk from Nelson Mandela that says, "It always seems impossible until it's done." And
Yeah.
this was one of those exact moments where, when I was successful in getting it mandated, and then not just mandating it, making it so that the executives, whose calendars are the worst, right? We never have any space on our calendar. I said, not only are we going to be able to do this as a mandate, but we executives will lead the charge and we'll do it first and we'll prove to everyone else that not only can it get done, it can be done successfully and it can be life altering. And so we did. And so we created what is called the Compass program. And it is a year long 44-hour anti racism training. We have now scaled it back to 36 hours because we had it 44 hours for executive and senior leadership. And then for everyone else, we scaled it down because the, the higher level leaders had to do like a capstone at the end to figure out how are they going to be creating different choices and impacting their department's strategy as a result of this training. And so other people didn't have to do that. So it's down to like 36 hours. And we just this past July celebrated graduating the first 7,000 employees that we've gone
Wow.
through. It took us almost 3 years to get them done, 2.5 years to get them all done. And now we're moving into sort of the maintenance mode, right? Like, have you done the
Right.
intensive mode? And so there's like Compass 2.0 that's getting developed and how we're going to keep going. And of course, every time there's a new hire, right? Because it's a requirement for having the badge. If you work here, you have to go through it. So this constant cycle of new people coming on and maintaining the education and awareness of this like first iteration and then what is the next iteration, because racism isn't the end all be all. It is the beginning because it is the foundation of where all the inequities come from. But then you've got the intersectionalities of gender identity, and social economic things and religion and all these added stuff, ability and disability. Those things are intersectional. And so when you start adding those elements in that impact inequities, inevitably race starts at the base, but then you go from there. So we've got to build the program up. But that first year-long anti-racism success story is still one of the ones that I feel like is my Oprah moment, and I can just like retire in peace saying, I did this impossible thing.
Yeah. We all need those Oprah moments.
Yes.
In curious how you leverage technology in the education and then the credentialing or badge management.
Yeah. So it's challenging when you think of like technology and data in this space, and because an it's a problem that is as old as the founding of this country, and yet it's still very new in figuring out how to address it, right? So there are a lot of tools out there that are massive data collectors, survey tools,
Right.
cool, really innovative stuff, but they aren't really built to tackle this problem. So what we've been having to do and looking at the data that we are calculating is first really figuring out what data do we really want to have, right? Because there's an insane amount of data out there showing inequities, right? We know they exist. Hospitals love focusing on that kind of data. Healthcare loves focusing on that kind of data. I can't tell you how many times I've said, if I go to another healthcare conference that tells me that there are inequities in medicine, I'm going to like kill somebody. Like, it's ridiculous, right? Like, everybody gets it. Why am I not seeing data on, and this is what we tried and it didn't work. So
Right.
maybe we should try something different, right? Like, nobody's taking it to that next level. Everybody's saying, I know they said that, heart disease is worse in African American populations than anyone else. But how worse is it in this particular space? And everybody keeps wanting to ask more questions of how bad is. And I think it's just a fear of trying to figure out how to right the ship, right? Because one of my young team members always says that when you talk about inequities, it feels like you're painting, black on black on black on black, and it's just darkness and darkness and darkness, and no one knows how to get out of that darkness. And so to kind of think about fixing it feels monumental. It feels like you're climbing Everest on top of Everest on top of Everest on top of Everest. But we know the only way to do that is to go one step at a time. So we have to start figuring out ways to create data analytics that allows us to show this worked or it didn't work, right? There's opportunities in operations, there's opportunities in clinical metrics. We have created stuff with Qualtrics to try and really get at true, honest patient experiences and not what the government requires to do for regulatory requirements, right? The problem that we have to just own and address is that the healthcare system was not set up in any way, shape, or form to address these issues. The data that we must present and we must calculate does not ask the questions that are needed in order to get us out of an inequity space. So we have to be really creative and innovative in doing that. And it's gonna take a lot of people saying, I know this is the way they say to do it, but why don't we try doing it differently? And then being honest about it being successful or failing. And then having those conferences that say, you know what, we tried these things, it didn't work. Maybe it'll work in your space, or we tried this thing and it was fantastic. So you should try it too. I mean, that's how healthcare and medicine in general is promoted, right? Every time you go to a conference, it's I tried this new drug and this is what happened to my patient. They either failed or they got better. And that's how we learn in this space. But we haven't translated that into addressing inequities. And I think it's very much this fear of not knowing how to make that first step because no one has done it and no one knows how to be the first. But there's enough of us that are like, we got to try
Sure.
and we can do some things, right? They're like every little thing counts. So my team last year we hosted the first failure conference, and it was based off of health equity failures and success stories just within the Twin Cities area. It's like, tell me what you've worked on, different community organization to address inequities in every space that impacts healthcare. So there was stuff around education and kids getting to school safely and how buses and asthma, work and just air quality. It was like some really cool, amazing stuff that people were doing that were not necessarily focused on in the building of the hospital, but have direct impact and care. And they were like, this worked for us, this didn't work. The dialogue that was in that room was ridiculous. It was amazing. And we're hosting a second one coming up this November because everybody was like, this is what I needed. I needed to talk to people to be able to say, your idea is fantastic and this is how I'll support it. Or my idea I thought was fantastic and the data showed it wasn't. And so now we got to do something different or maybe tweak it and try it a different way. So we've got to start building what our data looks like because the current metrics that we have, they're just not set up to address inequities. And I am really exhausted about hearing that there's inequities there. We get it. There's not one bucket that doesn't exist. So I don't need any more data in that space.
Let's take a quick break. At Health Data Movers, we know that data migration isn't just about moving information from point A to point B. It's about making sure your clinical and operational data is accurate, accessible, and secure so your teams can focus on delivering care, not chasing records. Whether you're consolidating systems, switching EHRs, or sunsetting legacy data platforms, our data migration experts help you move confidently through complex transitions. We bring proven tools, repeatable processes, and deep healthcare experience to make your migration seamless. If you're planning a system change or even thinking about one, let's talk. You can learn more at healthdatamovers.com. Now, back to the show. Well, you mentioned Qualtrics as a method of aggregating data. How do you leverage the electronic health record in collecting and analyzing data?
Yeah, so right now we use it pretty basically because it again hasn't yet been tweaked to hit what I would like it to be able to hit. So we use it for your standard sort of demo data, right? Like who are the people that we're actually seeing? Where are their holes? One of the biggest fights that we have now is trying to figure out how to change Epic's identity labels. So, right, so for race and ethnicity, the options that are in the Epic system do not accurately reflect how people want to be identified. And it is going to take like an act of Congress before that can happen on a, like, as like a grand level on Epic. Everybody keeps telling me you have no idea how hard it is to lobby Epic to make any changes Epic wide, and I get it. So we're trying to figure out workarounds, but even something as simple as that is like, you can't identify me in your system the right way. You've bucketed me in something that is categorically false in how I see myself, how I identify, which is very important in how I am successful in my clinical, progress. I either feel fully seen and so therefore I pay attention and do what I'm supposed to do and have better outcomes, or I feel disrespected and then I don't trust you, I don't believe you, and then I have bad outcomes, right? So something as simple as getting my identity right, we don't do. We have the box for white, the box for black African American, right? The box for Hispanic. But there's so many elements within that. I tell the story, there's a big difference between me, my mother, and my father. All in the same category, all like from the same family, all checking the box, black African American. But my father was 100% Nigerian, has very different healthcare needs because his body had a very different way of growing up with a very different environment, food experience, etc., than my mother, who is a descendant of the enslaved in America in a hodgepodge of black, native, and white. Her body has a very different response with a very different history and very different way of how it behaves. And then me being a combo of all three of those. And yet we have to check the same box, but that doesn't really accurately reflect who I am and what may work for me and what may not work for me. And we don't pay attention to that level of like even just personalizing it to say, who do you say you are and how does that impact how you view your healthcare? My uncles in Nigeria do not care about their PSA numbers being higher than what the United States would tolerate and claim it's prostate cancer and would have a fit. They claim that that's numbers they live with all the time. So they're not impacted. They're not all dying from prostate cancer. But if they brought those numbers here to the US, that data point would flag in the system and everybody would be racing to try to get them into an urologist and oncologist to get it checked out. Like even just the mentality around it is very different. So if Epic could just allow me to identify myself the way that I see myself, that I think would be very powerful because it would also allow us to do better stratification of groups of populations of people. When we say our numbers are that our Hispanic patients have more C-sections than vaginal births here, what does that actually mean? Who are Hispanic patients? We have a significant number of Ecuadorian people and we have a significant number of Mexican people. Those are not the same people. They have very different life oranges. So why is that all the same bucket? And it is a very American based phenomenon to see people in one way and just kind of group them in that one bucket. And that's a really hard thing for us to get out of and to change. And so if if I could get Epic to just listen and say, allow me to give people more categories so that we can better populate the electronic medical record with those sub buckets that are actually more influential to healthcare outcomes than this big category, then we could probably do some significant like data mining and research on the subpopulations and why this group is responding better than this group, yet they're still under the same, bigger umbrella of Native American. But Native American from these particular tribes is different than Native Americans from this different distant tribe, but we can't do that. So even like something as simple as that. So right now, I just use it to give me my buckets and say 75% of my patient population are of color. Great. Out of those, these are the ones who have all the health disparity based data points that our population health elements under Epic allow us to find out. Sweet. So we're gonna do food securities, consultation on this portion versus that portion. And it's so surface level and benign that I don't even really use it for anything more than checking boxes of making sure that we follow regulatory stuff.
Got it. Well, definitely appreciate the level of insight into the categorization. I couldn't help but thinking as you were walking us through that there must be some cross section between the issues you're presenting and personalized or precision medicine or even
Hmm.
genomics. But I may be totally off as I'm not a
No,
clinician.
no, you're actually right. Like the movement of precision slash personalized medicine it's going to be helpful in this space. The problem is that the people that they're focusing on are not actually the people that I think it really matters for the most in the beginning. I mean, I think everybody should have access for it, sure, but I think where we're missing is truly trying to get at the margins and centering on them so that all boats rise when we figure out how to do it for those who are the worst of the worst. And I think it would be fantastic to have better access to understanding not only what makes up the person but how they see themselves, right? Because perception matters a lot, and the difference between the quantitative and the qualitative data is significant when it comes to healthcare. Even though some people try to think that quantitative data is better than qualitative, they both impact people's lives, and that lived experience has significant clinical outcomes, impact on clinical outcomes. In many cases, environmental things do, right? Versus the cellular level quantitative data.
And to that point, talking about environment and impact, what are some of the most impactful ways? And I know you mentioned training and you mentioned the failure conference, but maybe from a broader lens, how Hennepin Healthcare is working to rebuild trust in communities that have been historically underserved by the medical system.
Yeah. Well, for us, what we've really focused on is how impactful it is to be seen as being true to our word and building trust. Trust is something that healthcare has always tried to pretend they've had in all communities, that somehow it was lost. Like in the African American community, people like to say, oh, Tuskegee was the reason why Black people don't trust healthcare. That is not true. It's just categorically false. Most Black people have no idea what Tuskegee was, let alone the reason why Tuskegee existed, and it didn't impact their rationale for why they don't go to doctors now. Many have had grandparents, neighbors, aunties, uncles, elders, church people say, don't trust those white doctors, they do X to you. And they believe that, right? Over some age old study that was done that no one really paid attention to, as an impact, right? So, really understanding that the trust between medicine and communities that have been historically marginalized has never been there. And then what do we need to do to create a trusting environment so that we can now establish what that relationship looks like to impact and improve? That's where we've focused on that the most. So we've told our community here the building of this health equity team, the focus on anti-racism work in the beginning, and the like truly going in hard and battling those headwinds is what we promise we will do, even against all the odds, with all the pushback, all the ignorance, all the fighting, all of that. We will keep every day following Harriet Tubman's mantra of just keep going. And that's what we've done, and we have been very successful in a lot of ways in getting that done. The fight is hard. I don't know if I can stress that enough, of how difficult it is, to continue to keep going. But we also have promised that we're never going to give up, right? So we have no other choice. 75% of the people who come to us are from historically marginalized backgrounds. If we can't figure out how to take care of them to the best of our ability, then why do we even exist? So we have no other choice but to keep going despite the fight, and despite feeling like we're being broken every day by this, and having it be so hard that I've got to create like mental health days for my young team members who just got out of school, who are really excited to change the world, and then the world actually really hits them in the face and they go, holy crap, I didn't realize how hard this was. I'm like, take a mental health day or five. But we have to continue moving forward because we have no other option. And the community has seen successes in that, and they are starting to trust us. And for me, that is the measure that I go for the most. Like, I don't care if my dashboards turn green, I don't care if my data points look better. I do care that there's a story of a woman who came into our emergency room with a new diagnosis of pancreatic cancer, all the way from Ohio. And when asked, why did you leave Ohio, which has, the world famous Cleveland Clinic and all these other things, to come to Minnesota to go to Hennepin Healthcare, her response was, my sister lives here. And she said, this hospital is the hospital that knows how to take care of Black people. That to me is the win. And so that's what we're going to keep trying to do, is creating those opportunities for people to see us as folks who actually are paying attention and doing the work necessary for everyone who comes in our doors to have the most successful outcome that they can.
Definitely inspiring story, and leads me to the question, and this may be very well what gives you hope. But the question is, yeah, what gives you hope when it comes to the future of health equity in U.S. healthcare?
The hope for me is knowing that even though it feels like we're all alone in this, we're really not. Um, Heather McGee, who wrote the book, The Sum of Us, it was an incredible book. You should read it if you haven't read it. She has a quote that she said in a talk that I heard her give. She said, somebody asked her, like, how did you survive doing this very challenging work on racism and economics in America, right? And she said, and this has really hit me hard, and this is what I hold on to now the most, is in order to get through this, she realized you have to fully face the dark in order to see the stars shine. And I feel like that's our current moment. Feels very, very dark. But we don't just sit in this darkness and it's by ourselves. There are millions of stars that are trying to shine through, of people who don't agree, who don't believe in the anger and the inequity and the unfairness and the lies and all the things that are making people feel really sad and hopeless. And those are the stars. And I fully believe that there are way more stars out there if we all just like focused in and just like fully face the darkness in front of us. We will see those stars and then we'll band together and become this bright light that breaks up the darkness. So that's what I'm going with. It's like there, even despite how concentrated and targeted it has been to go against the work that has to be done in order to bring equality into America, it's not going to be broken. These paths will still be walked. The people who are still doing this work will still keep fighting, and the stars will still band together against this darkness.
Beautiful analogy, and you know, um, every opportunity that there is to find that light, I'm sure is even more meaningful. So definitely appreciate that perspective. So, Nneka, this has been a fantastic conversation, and I have to say, I have learned a tremendous amount, particularly the cross section of genomics, precision medicine, personalized medicine with health equity. Your ability to get, well, yeah, huge kudos on your ability to get a training program through. I can attest that is a true labor
Another
of
Oprah
love.
moment. Yes.
Yeah, yeah, and also love the I remember hearing about failure conferences kind of in the 2010s, I want to say, in like
Mm,
as a Silicon Valley phenomenon. So really cool. I'm not sure if that was inspired at all, but cool to see the parallels there. You also are clearly an amazing leader, and would
thank you.
love to close and just well, and also you've clearly shown through this conversation how you know how to persevere and push people to persevere. But final question would be, for someone who's starting off in healthcare, across all the different roles, what might be some advice that you would give yourself when you were in their shoes, knowing what you know now?
Oh, gosh. Oh, I think the best advice I would give is realizing that everything is figure outable.
Hmm.
It really is. There is nothing that we can accomplish if we really focus, join together, diversify thought, be innovative, creative, and not be scared to try stuff and fail and try again. Because everything is figure outable. So anytime you come up against a barrier where it feels like there's no way to go forward or there's no progress, or right now, even currently in our hospital system, we feeling like there's a significant setback, it's still okay, because the two steps back that we now have to take will allow us to take four steps forward if we just continue to persevere and keep going, because it's all figure outable.
Love it. It sounds a lot like our internal mantra, we make it happen. And it really is the power of mindset. So thank you so much for your time today. Thank you so much for sharing your stories, providing incredible insight on the work that you all are doing at Hennepin Healthcare. Thanks again for listening to Quick Hits, a healthcare technology podcast for healthcare technology professionals. Follow us on Spotify or Apple Podcasts, and don't forget to reach out to us with feedback, suggestions, or even people in the healthcare technology industry you think we should interview. Send an email to quickhits@healthdatamovers.com.